The motion of today's debate is informal caregiving lies on the continuum of care. First, we will define informal caregiving as care provided to an older person by someone who they share a social relationship with. This is usually their spouse or child. Unlike formal caregiving, informal caregiving is usually unpaid and are not contractually binding in terms of the responsibilities and duration of care. Additionally, the care is usually provided by someone who is not a professional healthcare provider. Next, we define continuum of care as the practice of providing consistent and coordinated healthcare for patients. This ensures a seamless transition from one type of care to another. A common continuum of care in the elderly is as follows. Preventative care, such as pre-diabetes medical checkup, followed by inpatient care, such as hip replacement surgery after a fall. Outpatient care can include wound dressing or taking medication for chronic diseases. Rehabilitation helps the patient to regain ability to do basic activities. For those who are unable to perform basic activities on their own, they may be sent to a nursing home and possibly hospice for end-of-life care. As you can see, each element on this continuum of care plays an important role in the health outcome of a patient. These services are also used by a large portion of the older adult population. Like formal caregiving, informal caregiving also provides assistance for ADLs such as eating, bathing, and dressing. They also assist in IADLs such as managing medication and cleanliness of the home. For example, in Mr. Stephen Lim's case, he was involved in coordinating meals through Meals on Wheels program for his father. Informal caregiving is actually common among the elderly population. This could be due to preference to be taken care of by someone who they are familiar with. Other factors could also be limited options for formal care or financial limitations. In fact, 8% of Singapore residents regularly provide informal care. With the rising demand in elderly care, institutions have to keep up with the demand. Otherwise, we can expect informal caregiving to be more common in the future. By 2067, the demand for informal care is actually expected to rise by 257%. Since informal caregiving still provides the same care and is used by a portion of the elderly population, informal caregiving does lie on the continuum of care.
The opposition believes that informal caregiving does not lie on the continuum of care, as it may impede it due to limited knowledge and resources. So, firstly, on limited knowledge, caregivers might lack the necessary training required to provide adequate care. So, as the name suggests, most caregivers are not formally trained and tend to provide care based on their knowledge at the time. However, as the demands of care may increase in complexity in terms of medical care or quality of life care, untrained caregivers might end up providing suboptimal care. So an example that we can see is from the human library session with Stephen Lim. So with insufficient knowledge, Stephen placed his father's erectile dysfunction issue on the same level as his impaired vision. So this created a situation where the focus was divided between two issues, increasing the time and effort needed to solve either issue. Stephen has also commented that if he had a chance to do it again, he would have focused on the visual impairment issues instead of the ED issues. So next, on the limited resources, caregivers might not be able to provide the support an organization might have. Using Stephen as an example again, compared to organizations such as Guide Dogs Singapore, Stephen is less likely to have comparable resources, such as contacts for securing the guide dogs, trainers to teach him how to handle a guide dog, or even hiring a guide dog at a subsidized rate. So these resources are built up by specialized organizations over time and tend to be more comprehensive than resources available by informal caregiving. With the limited knowledge and resources, caregivers might not provide an adequate level of care that can be matched with the continuum of care. So this results in suboptimal care for the individual, and hence informal caregiving does not lie on the continuum of care.
The opposition discussed that suboptimal care due to limited resources and knowledge can hinder the elderly's health. On the contrary, the proposition believes that with sufficient training, informal care has the potential to improve health outcomes. Information and resources are readily accessible and provided by institutions such as AIC. They provide booklets for tips for informal caregiving, such as how to properly move someone from the bed to the wheelchair. It also provides links to financial schemes to reduce the financial burdens of care. Importantly, they also provide resources for caregivers to lower the risk of burnout. For those who can't afford to receive formal care, informal care is still beneficial to improve health outcomes. Informal caregivers can provide emotional support. This is especially important when transiting between different care providers. Adapting to change can be difficult. Thus, social support can help to alleviate stress and loneliness. It can also increase optimism and sense of self-efficacy. For elderly with cognitive decline, caregivers can remind them to take their medication, thus maintaining treatment adherence. Furthermore, informal caregivers have greater incentive to spend time to bond with their older adults. This not only stimulates the elderly's cognition, but also strengthens their relationships with their caregivers. Considering all the benefits of informal care in improving the patient outcome, it should lie on the continuum of care.
To rebut the proposition's first point, informal caregiving is not universally available. By saying that informal caregiving lies on the continuum of care, we are saying that informal caregiving is an integral aspect that everyone would have access to and use. However, this is typically not the case. Firstly, cultural differences create differences in how informal caregiving is prioritized. Asian countries tend to prioritize female priority, and this shows up as informal caregiving, especially in times of need. In Western individualized countries, families prioritize neoliberal logic and are less likely to practice informal caregiving, as they believe health is a matter of individual risk, choice, and responsibility. Hence, the different cultural expectations reduces the availability of informal caregiving across settings. Personal circumstances also reduce the availability of informal caregiving. There are individuals who simply are unable to function as caregivers on top of their existing roles, resulting in role conflict. An example will be an employee who works long hours and is also a parent. Coupled with the role of a caregiver, they might be unable to cope, and this eliminates the possibility of informal caregiving in that situation. In summary, cultural differences can be thought of as I don't want to or feel like I have to do this, while personal circumstances can be thought of as I simply cannot do this. These factors effectively prevents informal caregiving from being universally available. It is a stage that not everyone will utilize or go through, and hence it does not lie on the continuum of care.
Informal caregiving is often dismissed from the continuum of care primarily because it lacks the structure and definition of institutionalized care. However, if we revisit the core of what continuum of care actually means, which is holistic, consistent, and coordinated healthcare, it becomes evident that informal caregiving is a pillar of this continuum, despite its informal nature. A lack of institutional recognition does not diminish its role. Current global trends suggest a heavy reliance on such care, which might indicate how in reality we might not be able to merely ignore informal caregiving altogether. AARP, an interest group focused on well-being of those over 50 in the United States, provides some statistics on this. So 46% of informal caregivers manage medication and other minor medical tasks. 57% of informal caregivers also feel that providing and performing clinical tasks isn't a choice, but a necessity. So in a perfect scenario, one might advocate for all caregiving to be managed through formal systems. But the fact that there's such a heavy reliance on informal care perhaps highlights the inherent constraints of formalized care and underscores the indispensable role of informal caregiving. Diving deeper into this, on why this could be the case, firstly, trust emerges as a pivotal reason for preferring informal care. Families often find solace in entrusting their loved ones to familiar faces, mitigating concerns of neglect or mistreatment. This also adds to a sense of security by the elderly themselves, whom, when accompanied by a familiar face during medical visits, experience reduced anxiety. On top of this, it could also just be another innate part of culture to have informal care. For instance, African American caregivers majority who find a sense of purpose and meaning in their role, despite often reporting how these informal caregivers face more health problems than white caregivers. This could reflect some cultural beliefs of what the purpose of life means to them. So in essence, the global reliance on informal caregiving underscores its essential place in the continuum of care. Our world, which has diverse cultures and needs, leans on this pillar, hence making it an integral part of this holistic healthcare.
The second opposition point is that the focus of continuum of care and informal caregiving is different. Continuum of care focuses on the integration of primary care, while informal caregiving focuses on constant, round-the-clock help and support. Hence, continuum of care involves a macro focus where it functions through broad public health policy to ensure a well-integrated healthcare system and equitable distribution of services. Institutionalized care is also episodic and applied in the same manner for all patients, making this type of aid general. However, integrated healthcare also acknowledges the importance of a person-focused design. Yet, thus far, policies take this to mean understanding the personal meaning of an illness in terms of personal preference, needs, and values, and does not recognize the role of the informal caregiver in providing such tailored support. In contrast, informal caregiving involves a micro focus that provides support for loved ones outside of healthcare. This includes providing day-to-day assistance, such as household work, social and emotional support, and practical support in navigating healthcare treatments. Additionally, informal caregivers focus on personalized care and support, where care may be perceived as a function of commitment and affection. Hence, informal caregiving does not lie on continuum of care because it operates on a different level with a different focus.
Informal caregivers often bridges and fills the gaps between informal care systems and hence by virtue of that makes it a necessary part of the continuum of care. Looking at the continuum of care from a teleological perspective, its main aim is for holistic care for the patient. If the aim is truly to achieve a holistic care for patients, there are things that formal care cannot provide due to practical and feasible limitations. Firstly, elderly patients often require holistic attention. Family members often possess a profound understanding of the recipient's preferences, history, and needs. This is important for elderly patients who are unable to live independently. This is important to guide more tailored decisions about the patient's care, where the family members can often be the voice for the patient. For example, Jehovah's Witness cannot undergo blood transfusions. Family members caring for these elderly individuals can ensure this crucial information is communicated in medical situations. This approach promotes more personalized care as it respects the patient's unique beliefs and values rather than applying a one-size-fits-all solution. Second, the strength of informal caregiving lies in the profound emotional bond it can foster. A shared history between the caregiver and the care receiver naturally paves the way for a deeper emotional connection. Such bonds not only facilitate better understanding and trust, but also infuse the caregiving process with a sense of purpose and meaningfulness for both parties. In contrast, formal caregiving settings might lack this depth of connection. While professional boundaries are essential, they can sometimes act as barriers, limiting the emotional closeness and personal understanding that naturally arise in informal caregiving relationships. Lastly, the importance of consistency and familiarity in caregiving, especially in certain contexts, such as Alzheimer's disease, cannot be overstated. Continuity in caregiving is pivotal as frequent changes in caregivers can be disorienting and stressful for individuals receiving the care. The presence of a familiar face and setting can provide significant comfort and stability to patients. Moreover, having someone they can recognize and trust by their side can greatly reduce feelings of embarrassment they might experience in the presence of strangers, allowing for greater ability to express the problems they face to allow for more holistic treatment outcomes.
Now we'll discuss briefly on our common position. As previously mentioned throughout our debate, informal caregivers are extremely helpful in improving health outcomes for those under their care. Apart from assisting in ADLs and IADLs, they also provide social and emotional support. During the transitioning phase between care providers, their consistent and familiar presence help to lower stress and loneliness. Informal caregivers are also not restricted by professional rules. This gives them greater autonomy to respect the elderly's preferences. Finally, they advocate for the elderly to maintain a standard of care that's provided by professional healthcare workers. Despite the important role of informal caregivers, informal caregiving has not been established as part of the continuum of care. Thus, it is important to restructure the current framework to include informal caregiving.
Next up, including informal caregiving is important for several reasons. Firstly, it tackles the stigma associated with informal caregiving. Negative perceptions, such as the practice being burdensome or pointless, should be counteracted as it fails to take into account the multiple benefits of providing caregiving. Providing knowledge has been one method of counteracting stigma. Next, it also helps to shape future policies. Informal caregiving has traditionally been difficult to quantify as it is intangible. However, policies regarding healthcare has a great impact on caregiving, and including informal caregiving creates a greater basis for formulation of future policies rooted in different social and cultural contexts. Finally, it acts to support research. Formally introducing informal caregiving into continuum of care sets precedents for researchers to take informal caregiving into consideration. Not doing so leaves it optional and creates a willful knowledge gap.
Caregivers are often unsung heroes, and some countries are leading the way in recognizing their importance. In countries like Australia, one major initiative they have is the Carer Gateway, which is a national online and phone service that provides practical information for informal caregivers. In countries like Canada, where they have Carers Canada, they provide support networks ensuring that caregivers' own mental well-being isn't neglected, and also offer vital counseling services for them. In countries like Germany, they provide monetary allowance given to those who are being cared for, usually by relatives. On the research front, there's plenty to be excited about, especially in countries like Japan, which is diving deep into technological advancements to aid informal caregivers. Together, these nations light the path forward, reminding us that caregivers too need care.
In conclusion, we would lean towards including informal care as part of the continuum of care. Informal caregiving is an essential part of the integrated system of care because it offers aid navigating healthcare systems, which thus enhances the transition. It significantly contributes to ensuring consistent and coordinated healthcare and seamless transition from one type of care to another. Additionally, it offers emotional, social, and practical support outside of healthcare. Thus, it should be recognized as a component on the continuum of care, even if it is not an official healthcare system. Thank you for listening, and these are our references.